Care webinar, Care for the Dying, Listening to God. We welcome Dr. Tom Miller today, who will be teaching us and guiding us and providing a lot of wisdom from his experience in this line of work. We thank Leadership 100 for their generous support so that we could resurrect these webinars. For those of you who have tuned in before, we've had a hiatus of probably about 6 months, and that was due to some budget constraints. However, Leadership 100 very recently gave us a generous grant so that we have use of this platform of Zoom once again. This topic, Care for the Dying, Listening to God, some might think that this would just be for priests, not for priests and their wives. However, for those of us who are clergy wives, we know that sometimes we can be at the forefront also of ministry to the sick and the dying and to their families. And even if we're not in the forefront in any way, perhaps not making hospital visitations with our husbands, not really being beside them, sometimes people will approach us about these things. And more importantly, when our husbands come home after having ministered to the sick and the dying and their families, we are part of the important support that they receive. And the psychological world has a term for this now. When we care for the sick and the dying, when we suffer with those who suffer, as well as rejoice with those who rejoice, but now we're talking about the suffering piece, we experience what's called vicarious suffering. And this is when we walk beside somebody else who is suffering. So as wives, we may not be walking beside those who are suffering in the same way that our husbands do, but we are providing love, support, and compassion for them after they have done so. So this topic is really important, both for clergy husbands and wives. Dr. Tom Miller has been a physician for 40 years, and for the last 15 years, he has devoted his life to working with the sick and the dying in palliative care and hospice care. His wife Jill is a nurse who works in hospice care. So together, this really is a vocation for them. And when I heard him speak several months ago at a conference, the passion and the care that he has for the people he's working with clearly came across, and he had an awful lot to offer to us. He and his wife live in Lancaster, Pennsylvania. In their former years, they were Mennonites, and they were actually missionaries in Albania when they were exposed to Father Luke Veronis's ministry when he was a long-term missionary in Albania, and that was the beginning of their journey to Orthodoxy. Presently, they worship at Annunciation Greek Orthodox Church in Lancaster. Just one housekeeping item. At the bottom of your screen, you will see a question and answer box. If you have any questions during this webinar, please type it in, and I will be moderating the questions throughout this next hour that we're together. Dr. Miller's going to be breaking up his presentation into segments, and after each segment, there will be opportunity for questions and answers, but you can type in your questions at any time. Dr. Miller, thank you so much for doing this and for being with us.
Thank you, Carrie. It's really good to be with you all. I appreciate this opportunity. I want to start with a prayer. Let's pray. Lord Jesus Christ, Son of God, we thank you for this day and the opportunity to speak together, and for the technology and the people with expertise to bring us together. Now we bring our expectations, our own agenda, our egos, and lay them at your feet. Guide our thoughts and feelings. Help us to speak firmly and wisely without embittering or embarrassing others. Prepare our hearts for your grace in this webinar. In the name of the Father, Son, and the Holy Spirit. Amen. So I really do appreciate the opportunity to be with you all today. I think the greatest opportunity to be the face of Christ in a parishioner's life and in the family of very many parishioners is at the time of serious illness and death. That's the time when eternity speaks the loudest to our lives. So I kind of want to think through a framework of orientation to try to frame what I've been seeing in the many years that I've been working as a physician. And the framework kind of frames the culture that we're in. And it informs the medical culture, which is its own particular culture, and it informs the greater culture that our parishioners are swimming in. I just read recently that orthodoxy shouldn't be considered an ethical framework or a way to live a good life, but it's actually an orientation. It's an orientation towards God. And it's the goal of our existence is to journey towards Him. And the importance of that journey is that it necessitates repentance as we get closer to God. This is different than the orientation of our modern world. In the modern world, man is supposed to be independent. Man is supposed to be able to choose what kind of life you live. Like you're going through a cafeteria, and you might try this, you might like that, and you choose that kind of life you want to live. And Father Stephen Freeman says that it's a consumer society. He says, just in his blog on the 15th of May, he just said, what constitutes a full life? In consumer culture, it would be maximum consumption, enjoyment, and productivity. And he says that in this kind of framework, there's really no place for suffering and death. These can only be seen as a failure and a misfortune. And our culture will support every false hope that promises relief from suffering. This is quite different from the Orthodox orientation that says that God's grace infuses everything. God is part of every part of our physical world. And our whole world speaks about God. The modern world finds a way to this sort of meaning as heavy. It's a heavy burden, and would rather be free of it and relegate God to the second story, as Father Freeman says. He says that there's actually a two-story universe in the framework of the modern world. We'll put God into the second story and end up living our lives without Him, bringing Him down when we think that we're in trouble and need some help. This is not the Orthodox point of view. I would like to point out, and the Orthodox point of view sees God in everything. We also have difficulties setting limits, or even accepting limits. If we expect that this world is there for our own pleasure and we can pick and choose the good life we live, there should be no limit to that. Freedom is defined in terms of choice and lack of limits. That's very different from the Orthodox view of freedom from the things that enslave us and enslave our souls. This worldview comes into question when limits are found with illness and the limit of life when we come to the end of our lives. We can't argue that our lives are limited. R.J. Snell is a professor in Eastern University, and he has a quote that says, well, he calls our world the empire of desire. And he says, the empire of desire finds limits abhorrent. And Father Stephen Freeman calls this orientation the consumer self. So I think I have tried to frame this in a way that is theologically correct, but I am not Orthodox by birth and have not studied in a seminary, so I would appreciate any comments on that. If you have them at this time, I'd be willing to hear them now, and then, or if you have them later, we can hear them at that point.
Tom, can you make the connection for us of what you've just said to a very specific topic that you're going to be addressing?
Yeah. I think that I'd like to talk about two areas. One area would be how this worldview affects medicine and the practice of medicine. And the second would be how this worldview affects what patients and families bring to serious illness. So maybe I'll start with medicine. Is that all right?
Sure.
Okay. Modern medicine has really adopted this worldview, and it feels like there is no end to the progress that we can make. That this progress that we are making is limitless. And if you compare what we've done in the last 50 years in medicine to what was happening with health and illness in the years past, we've made great strides, of course. But there seems to be no limit. We keep pressing the limits further and further, and it's costing us more and more to try to press these limits. That's one of the main gods of modern medicine, is limitless progress. We feel like we're going to beat cancer, we're going to live indefinitely, we're going to always maintain our good function and ability to do things. Modern medicine is focused on prolonging life at all costs. It can't accept the fact that life is limited. So you'll find the ICU patients going through serious illnesses at all costs, being put on ventilators and unable to speak, and finding that there cannot be a limit to how much we do to them. There was an author back in the 70s, Ivan Illich, who talked about Prometheus, and how in this myth of the Greek semigod Prometheus, he stole fire from the gods. He was greedy, and he thought he had to have something that the gods only would have. So he stole fire from them. Well, they caught Prometheus and made him tied to a rock where the eagles would pick his liver every day. And then at nighttime, this liver would regenerate, and only to find himself tied to the rock the next day and have his liver picked again. And that was a real apt description of what we do to people as they're coming close to death, and we put them in the ICU and make them go through all sorts of difficult and torturous treatments, only to bring them back and then go through it again the next day and the next day and the next day. And in the end, we don't accomplish a whole lot by trying to prolong life when we see that life is not going to be able to be prolonged. Doctors, go ahead.
So a priest is in a situation where somebody needs life support to continue to live, and the family does not want to let the person go. Are you going to address something like this a little bit later? Am I asking this too soon, or is this something you could attend to right now?
I think we can talk about it now. I think it's worthwhile talking about now. I think you have to put everything into its context. When a person comes to the end of their lives, very often they're losing parts of their lives little by little, and it's a relentless decline. So if you have a person on life support who is at the end of their life, after you've seen a a relentless decline, or the organs of the body have shut down and there's very little hope that this is going to improve. A priest needs to talk to the family about the goals of what you expect out of this kind of care. A lot of times a person will be kept alive on machines by the grief of the loved one. A wife of 45 years can't bear the thought of losing her husband, and so will ask the doctors to prolong the life as much as possible. But the inevitable can't be avoided. So I'm thinking that in each case, you have to think through the context of the patient. What is the story of what's led up to this point? What are the things that are keeping the family from withdrawing life support when it looks like everything is hopeless? I think that's the job of the priest, as well as a physician who's willing to take that kind of time. But you have to learn the context of what the person is going through at this point, has gone through. If it's a 45-year-old young man who has gone through an accident and the organs are shutting down, but there is a chance that he could be pulled through, you might want to go through more rigorous care in order to see if you can achieve that result. But one of the things we often offer patients and families is that we can give them a time-limited trial. This desperate kind of care that we often provide people when life is being threatened is very hard on their bodies and shouldn't be continued indefinitely. But we could offer a time-limited trial for this kind of care with the expectation that if this care is working, then we'll see certain results. We'll see that we will achieve this or that. This is what we would expect. If we don't receive those kind of results in that a limited amount of time, continuing this kind of care is probably not going to be productive. A priest could be involved in that kind of discussion as well and would be very, very helpful in that discussion. One of the other issues that we see with modern medicine is that it's very fact-based. It's had a lot of success in dealing with serious illness by using facts and applying them scientifically. But I just read a comment by a physician this morning who said, you know, if I can't see a CAT scan or a lab test or something that I can put my finger on, I'm not going to believe it. I don't think it exists. It's quite different from the Orthodox perspective that acknowledges a reality beyond what we see. Like the Greek term for truth. Do you know the Greek word for truth? It's, what is it?
Aletheia.
Aletheia, thank you. Yeah. And I'm led to believe that that word means it reveals what's already there, which is different from the Greek word veritas, which means what you can verify, facts. And physicians and medical people are steeped in facts, in veritas. That's the world they live in. So it's hard for them to really understand the context of a person, how a story fits into a person's illness, and how to proceed when a person doesn't follow the facts of the case that they have. There are things that can't be well defined in medical terms. Even death is hard to define in medical terms. We struggle to do that sometimes, especially when you think of declaring a person dead for organ transplant purposes. Medicine has a hard time defining things that aren't in the world of veritas. So very often people who come into the hospital with serious illness, they're seen out of their context. What happens at home, who's their loved ones, the story of their life, the thread of their life, what's important to them, all is very, very secondary to the facts, the CAT scans, the renal functions, those things that are verifiable on the doctor's chart.
That's very interesting, Tom, because you're looking at the whole person, where oftentimes in the emergency room in the hospital, the physician doesn't know the person and only is looking at, like you said, the medical facts. And this is where a priest can really help minister in these kinds of situations too.
Yes, and I think that it's important for the priest to be able to explain the person to the medical people too. Sometimes families and patients don't seem to have a voice, but a priest who knows the person and parishioner would be able to explain the context to the medical team, which might provide some guidance for them then too. We often find that's the case.
And generally in medicine, are physicians open to that, to hearing from clergy?
Yeah, generally they are. I think they welcome it because they're always looking for direction for how to proceed. But there's also some arrogance in medicine, like anything else. And so it's not too unusual to find that those kind of things are found to be irrelevant to the facts at hand. And so they might be ignored. But I think it's always worthwhile for clergy to be an advocate and a go-between. The other thing we find is that that physicians will avoid emotion, and they'll avoid things that that will elicit emotion. So, for example, when talking about a person with cancer, they'll talk about not the cancer that's in the liver, but the lesions that are in the liver. If they talk to the patient about the lesions or the mass, it's not the same as saying the malignancy. So that kind of thing doesn't elicit the emotions that the more direct word or the more specific word would elicit. So very often I've seen patients who have talked to the doctor. I've talked to the doctor after he's talked to the patient. Doctor said, yes, I've told the patient about their cancer and what's going on with them. And I find from the patient, they feel they were told there's something there that's a mass. They said, but he didn't say I had cancer, so I'm okay. So it's an easy way for a doctor to get through a difficult conversation without eliciting emotions or having to deal with them, because emotions are not fact-based in the way that physicians were taught to deal with things. And they're not taught to deal with emotions and to lead people through difficult discussions. Another way that you might see physicians handling things is, that are difficult because of the emotional impact is just to refer to another specialist or to order another test. I had an oncologist tell me one time that it's a whole lot easier when you know a cancer is advancing in a patient. It's a whole lot easier rather than to sit down and say your pain is due to cancer progression. It's a whole lot easier to say, I'll order another CAT scan and then send them out of the office and deal with it another time. So doctors will avoid things that will tend to not be fact-based and will be more emotional and context-oriented.
So what does that end up meaning then for the patient, for the family, and for the priest or clergy wife who may be ministering to them?
Yeah. It means that they have to look beyond, to the meaning beyond what they've been told, and maybe dig deeper and ask for that meaning from the medical people. And that can be a place where I've seen clergy actually assist, that to be a part of a meeting with a physician and to help get clarification, like to ask, what does this mean? Or when medical terms are used, to stop the physician and say, what does that mean? And to ask difficult questions that might be hard for a physician to answer, but are necessary to be answered, like questions about prognosis, or if we do this procedure, what is his life going to be like afterwards? Those are questions that physicians aren't usually interested in answering because it will elicit too much difficult conversation for them. Yet that's where we need to ask them to help us. And I think priests would be well positioned to do that. The patient and family bring their own orientation to this kind of discussion too. Patients and families also have trouble with limits like physicians do. I had a 92-year-old man who was dying a comfortable death after having lived a good life and a wonderful life, and things were going well with him. Yet he knew he was dying, so he looked up and asked, why is this happening to me? He was 92 years old. Limits aren't always accepted in our world. We have patients and families that have bought into the medical myth that with enough science we can fix anything and everything. And we see the extremes of this, like in cryogenics, where people are freezing their bodies thinking that they can thaw out in 45 years or whatever it is, when we have the technology to come back to life again. And we also see extreme efforts to seek cancer treatment. We want autonomy and choice, but are baffled sometimes by the choices that are presented to us. And sometimes physicians will honor this autonomy as the highest ethic that we have in our world. That for medicine, there's no ethic that trumps autonomy. So it's what the patient wants, what the patient desires is the most important thing, which goes back to the worldview that our choices are the most important thing that gives us freedom. So what I've seen in my practice is that I've seen physicians oftentimes offering choices that aren't choices. What I mean by that is they'll say, here, you pick, you choose what kind of treatment you want. There's this treatment on one hand and this treatment on the other hand. And in reality, it doesn't matter what treatment they pick. In certain situations, there is no choice. The patient is going to die. I'm thinking of an example of an oncologist one time who offered radiation therapy for a person who had cancer spread throughout the whole central nervous system, the spine and the brain. So she said to the family, you can choose this for your loved one, or you can choose hospice care. Those are the two things you can do. So I asked her, well, have you seen this work, this radiation treatment? And she said, well, she did consult the radiation oncologist and asked that question of him. And in the 15 years he had been working as a radiation oncologist, he never saw it work. So I said, so that's really not a choice. We would be putting this person through this treatment in order to do what? And she said, well, probably it wouldn't help at all. So let's not even talk about that as a choice. But she felt that in order to do the ethical thing, she had to offer choice. And so we see that playing out in medicine. That people are offered choices thinking that that's the right thing to do without giving straightforward advice about what we also find that patients and families will reach out to doctors and also religious sources too for a miracle. But when really the miracle they're asking for is just to return them to the life that they knew before, and the things that happen in this illness are transformative for them. Many people come to the end of their lives with this modern orientation and with choices now being limited and the freedom contracted and their possibilities pretty narrow and their resources are failing. And they're looking to medicine to restore them to their life with that orientation that Father Freeman talked about. And this is a time when eternity speaks pretty loudly, and it's a time to listen to God. I can tell you a story at this point. It's one that I got to witness. There was an 80-year-old man who came to our hospital, was dying of heart failure. And I learned that he was a chemical engineer. And I sat by his bedside and he said, first thing he said to me was, "You believe in God, don't you?" I said, "Yeah." "Why do you ask me that?" And he said, "I don't believe in God. Why don't you tell me why you believe in God? Try to convince me." And I said, "I don't think there's anything I can do to convince you." He said, "Well, why don't you tell me why you believe in God?" And I said, "I don't think there's something logical I can tell you about that, except that I have experienced that small, still voice. And that experience tells me there is a God, and that's why I do." And he just shook his head and he said, "Well, I don't believe in God," and so forth. He was a scientist. But I learned the story of his life. His father was a scientist in Germany. He was a chemical engineer in Germany as well. And it was during the time that the of World War II just getting its start with the Nazis taking over Germany. And he was actually working in the chemical company that was developing the chemical that exterminated the Jews in the gas chambers. So, and this man was married to a Jew. And the Nazis asked him to divorce her. And instead of doing that, he found a way to take his young family to the U.S. And so this man I was seeing in the bed was the son of this chemical engineer that was in Germany. So they had a very difficult life initially, and then found their life in the United States. When I came back to the bedside of this man several days later, he was declining. It was pretty clear that he didn't have long to live. And all of a sudden he looked at me and he said, "Did you touch me?" And I said, "No, I didn't touch you." But no one was around the bedside that could have touched him. I said, "So who touched you?" And he said nothing, but he had a different look on his face. So I said, "I think you know who touched you." And he continued with that look. And so I said, "So what was the touch like?" And he said, "It was really loving." So I said, "Yes, I think you know who it's like. Who touched you? I mean, do you want to tell us?" And he wouldn't say. So we talked a little bit more. And then later I touched him on the leg a little bit as I was saying goodbye. He said, "There you go, you touched me." I said, "Well, was that like the other one?" He said, "Nope, it wasn't nearly so loving." So there was something about that encounter that made me understand that this man experienced God. And we knew that. He knew it and I knew it. And he went on to go to our hospice inpatient unit in the next day or two, and he died within the following days. But he had a very peaceful death. I think he encountered God. I think that is sort of a model of how we should listen, because I really believe that God really comes close to people at times like this. They're without their own resources. The choices are limited. their orientation is ready to be changed. We really need priests and clergy's wives during times like this.
So, Tom, some questions have come in, seemingly taking two different directions. One is about possibly parishes doing some of this work with people before they're in these life and death situations, preparatory work about how we want to die, what are appropriate ways as Orthodox Christians to die. How do we do that in parish life? If people are more prepared before these things come up, then are they going to be better equipped when the emotions kick in and the situations come about where they're in crisis mode? And is there any work going on that you're aware of in the life of the church in terms of any preparing people for death?
The fathers have talked a lot about that in the some of the writings, so it's worthwhile reading some of the things where some of the fathers say you need to think about your death every day. What I would suggest is that we become more literate in the language of dying, and let it be more spoken about in sermons, maybe in seminars or retreats in our parishes. One of the ways I think we can do that is talk about living wills and advanced care planning. Those things are ways of setting out your wishes beforehand, putting limits on medical care that you don't feel would be appropriate for you. So I think that that's a very useful thing. It's a very practical thing. The living wills have some drawbacks in that they can't begin to foresee all the circumstances that they can be invoked. So it's hard to sometimes use living wills as a complete directive for care. On the other hand, it does open up the door in the discussion about what should occur at the end of life of a person. And I think those discussions can begin to open up doors for end of life discussions that are meaningful for the parish. There's some resources that I listed that will be available in the chat that might help all of us to become a little more literate and comfortable with talking about dying and serious illness.
Those resources just came up on the chat, and you'll see your chat down near the question and answer box on the bottom of your screen. Another question that came in, you talked about possibly the clergy being involved with goals of care conversations. Any specific pointers that you might have for conducting a goals of care conversation with a palliative or hospice appropriate patient who may be in denial?
We often encounter that, and one of the things that we can do, if denial is pretty obvious, that the situation is clear, one of the things, one of the tools I use is the words "I wish," and start from there. If a person believes that they're going to be cured of their heart failure, for example, by a procedure that we know is not going to work, I will often say, I wish this were the case. I wish this procedure would produce the results you're looking for. However, it's not real likely. Then we often say, it's good to hope for the best, but prepare for the worst. So some of that is script in a way, but I found it very helpful to use script on certain occasions. Not as a platitude, but as a way to help open up further discussion. It's also helpful to know where denial is coming from, to let the person sort of tell their story. And sometimes you can get clues in a story to pursue something that leads you in a certain direction. So denials are often some defense mechanism that people use for a while, and at times there comes a time when they can't use it anymore, and just be prepared for that. Sometimes you have to let people have their denial too, and just walk with that. If you've done those things, you've explored their story, said, I wish it would be different, but it doesn't look like that's the way it is, and they still hold on to their denial, I wouldn't work hard to take away their denial, because it's serving a purpose for them in some ways. But continue to walk with them. Don't give up and walk away and say, you're hopeless. But continue to walk with them. And usually there's a crack in that you can begin to use to move the case forward.
I remember one time years ago when I went with my husband to see somebody who was dying, and was just really holding on, no life support, nothing, but the person just had a really strong will. And somehow my husband had the discernment to know what to do in the situation, and he simply whispered in her ear, it's okay to let go. It's okay to die. And she died within a few hours. Now, I don't know if that had anything to do with it, but it was some, and he's been in that situation a few times where people just need the permission to let go and to enter into the bosom of our Lord.
I think there's a time for that, and I think you have to discern when that time is. There are some people who believe that you can't leave this earth until somebody said that to you. Mm-hmm. So that's not the case, and sometimes I think it's the wrong thing to say, because there are some people who that makes them dig in even more and say, wait a minute, you don't care for me? Or, so you have to discern that. But there is a time when that's appropriate. One of the things I wanted to say is that that you have to listen to what's going on when you come into a room. You can't come into a room where someone is dying and the family is present, and with your own agenda, knowing what it is you're going to say. You have to stop. I always, in those situations, stop and say the Jesus prayer a couple times, hopefully, before going in, because how do I know what's in the air when I come in? I don't know what's in the air. I often feel like I'm walking into a play that's already been written. And I'm going to say some lines. I don't know what those lines are before I go in. I need to be ready to listen to my cues. And then my lines come. And often things progress in a way they're meant to be, I think, in this play that has already been written. I didn't write the play, so I can't take any credit for it. I'm just sort of saying the lines. So I'm looking for the cues for my lines when I come in. So I would really urge clergy and their wives to not come in with an agenda, not just say the prayers. Come in first with a listening ear and kind of absorb the air that's in the room when you come in, and ask for discernment. Go ahead.
And what I'm really hearing from you is, when clergy go into these kinds of visits, they have to be willing to sit, to listen, to be with, to bear with, and to spend time. Not just to go in to do, like you said, quick prayer if the person is of right mind and able to receive Eucharist. It's not that. People really, and it's just not one other thing to get off their list to do for the day. But sometimes these situations really require that they do require that we devote all of what we have and what we've been given at Christ in that moment to be with that person.
Mm-hmm.
It's so
Harriet,
important.
I would say that this is the most important thing the priest can do that day, the very most important thing. There's probably not a place in a parishioner's life that a priest can play an important part as an ambassador of Christ than in this time. And the practical things I would say are just exactly what you said. Come into the room knowing that this is going to take time. Don't be rushed. Come into the room having prayed ahead of time. Drop your agenda at the door. Be ready to discern the atmosphere that's there and what God is saying to both you and the patient and family.
A question just came in.
Mhm.
What if we clergy have not yet made peace with our own limitations or mortality? How do priests minister when they have not
It's a really good question.
done this work yet themselves?
Some of my hardest patients have been clergy. They feel that God's work with them is so important that they can't leave this world. So that's really a good question. I don't know if I have good answers for that, except if you recognize that this is a question for your spiritual father, and this means that there's a lot of work ahead of you. And I would say become literate in the language of dying. Use the resources that I put here, and there are many more resources that the church has too. Other questions, Carrie?
That's it for now, in terms of the questions that have come in.
I would really want to encourage clergy to help their parishioners to look beyond medicine for help. I really feel like what I'm seeing in the hospital is that patients will look to medicine as the one and only help that they have. And I feel like they're coming to this time very unprepared, that there hasn't been a lot of work done in the church to help them get to that spot. There are a lot of things that can help parishioners get to that spot. I think of all the things, all the little losses we experience throughout our lives, whether it's loss of a job or loss of some expectation or another. Our clergy should really be in a position to help people frame that kind of thing. The little deaths that we all have in our lives. And in learning to deal with those things, we learn to accept our limits. We learn that instead of looking for more and more stuff, more and more enjoyment, we should be looking for God more and more. And those losses in our lives will teach us to do that. So there are many opportunities the clergy have to be working with parishioners as they go through their lives. People who have come to the end of their lives and tend to have peace, have learned to forgive and to accept forgiveness. And the hardest that's seen is when that's not happened. When there's strife within families and loved ones. Old wounds haven't been mended. There's not been repentance. And there seems to be no way to fix that, or the hearts are too hardened to fix that. And when that happens, there's no medicine that we can give that will alleviate that kind of suffering. It's spiritual medicine that people need, and that's best done by the clergy.
Question came in about what specific resources of the Orthodox Church have you found most helpful for these kinds of situations that you're Orthodox resources that you're aware of?
Yeah, I haven't been a big reader of the fathers, although, I'll read snippets and things that have been really helpful. So some of the sayings of the fathers have been really helpful. Father Stephen Freeman, I read a lot, and his blog has been very helpful in helping to gain some insights. Um, uh, Beacon Goroyan is an Orthodox theologian who's written a book called Living Towards Dying, if I remember right. So I've read that book about 4 times, maybe 5, I don't know, and realized that he really gives a good Orthodox perspective on how we're supposed to orient these thoughts about medicine and coming to the end of our lives. There's the author I mentioned before also is Ivan Illich. He's not Orthodox, but I think he's from a Romanian background or something, but he was Catholic, I believe. But he wrote a book called Medical Nemesis that I read when I was a resident back in the 70s and still a Mennonite. And it really resonated with me how medicine has become its own God. The Mennonites understand fallen powers. There was a theologian, John Howard Yoder, that talked about government being a fallen power. It was ordained by God, but just like humans, it falls into sin and destroys lives. So medicine, I think, has taken on the role of a fallen power as well. It asks more of people than what we should be giving it. It's become its own God, and people are giving their lives over to medicine. So I would say Ivan Illich and John Howard Yoder have been helpful. I just read something from St. Basil the other day. I'd like to quote. He says, whatever, St. Basil the Great, right? What was that, 4th century or something? Mm-hmm. Anyway, he says, whatever requires an undue amount of thought or trouble, or involves a large expenditure of effort in terms of our health, and causes our whole life to revolve, as it were, around solicitude for the flesh, must be avoided by Christians. He says, to place the hope of one's health in the hands of a doctor is an act of an irrational animal. This, nevertheless, is what we observe in the case of certain unhappy persons who do not hesitate to call their doctors their saviors. So there are a lot of things like this written to help us orient our medical care for ourselves in ways that make sense in our Christian lives. So yeah, I haven't begun to explore it, but those are some of the things that have come across my way here.
There are several questions coming in, so are you okay with my throwing these questions at you now?
Mm-hmm.
Okay.
Yes. Mm-hmm.
You mentioned increasing awareness of death within the parish, including in sermons. What lessons would you say are important to communicate to parishioners, and what are often neglected in your experience?
I think the lesson that we would benefit from is that there are limits to what we can do in medicine, and we need to find out what's important. I think the other lesson is what we talked about before, is keeping our slate clean all the time with forgiveness. Also, for people who we know may not live a long time, to talk to them like it could be the last time, anytime. That would be a lesson that would serve all of us well. I remember when my dad was dying in his 90s. He wasn't dying. We knew he couldn't live much longer than his 90s, right? So every time we said goodbye to him, we thought this could be the last time. And so we lived as if this could be the last time. And when he did die, I felt like we didn't have a whole lot of regrets. So helping parishioners to live without regrets, to repent.
Thank you. Uh, Priest wrote in, I visit with a woman who's 94 years old, in and out of hospital and hospice, and she keeps saying, as my father used to say, you never give up.
It's okay. I think as long as life is being fully lived without having to commit everything you own or are to medicine, that's good. Yeah. That's not
I think you just answered this person's following questions too with that comment. And he says that I ask her, what does it mean to give up? What does it mean to reach the end? So he's challenging her with some of these questions of coming near the end of her life.
Our society has some peculiar ideas about giving up. They feel that this is a failure. To give up is a failure. And I think the priest can be helpful in framing it in other ways, that this is not a failure. To give your life to God is not a failure, that's a success, right? And we pray every Sunday that the end of our lives should be, we hope that the end of our lives should be without shame and suffering, right? So this is something she can hope for too. We can all hope for that. That's the success, not a failure.
Somebody just offered the resource of Daniel Henshaw's book through St. Vladimir Seminary Press, Suffering and the Nature of Healing.
Yes, that's a good book, and he's a good resource. Yeah.
Okay, somebody did ask the question, whoever it was, about putting all of these resources on the screen. I think what we'll do is, following in the next couple of days, following this webinar, Tom, if you could get me an email with a list of resources, I'll add these few that have been mentioned, and we'll get out an email to all of those who registered for this webinar, okay?
Okay. Can I take 1 minute to do a couple of whole lists of don'ts?
Yes.
Would that be all right?
Yes.
Okay. A list of don'ts. Don't be rushed. Don't just read prayers and feel you've done your job. Don't say a bunch of platitudes like, everything happens for a reason, or there are others worse than you, or I know how you feel. You really don't know how you feel. God will never give you more than you can handle. Don't tell stories about yourself or other people, or let your parishioners tell some stories about your aunt who had the same kind of cancer. That's not helpful or comfortable to hear for the person who has an illness. Don't talk more than 50% of the time. Listen. Don't try to fix things with a prayer or an icon or a Bible verse or an attitude or a supplement or change an attitude. Don't try to fix. Just let things be. Let them be. Let them be in this atmosphere that you're in. Don't fix it. And don't look to the sick or the bereaved to try to comfort you. That's not their job. You're there to comfort them. So if the situation is too overwhelming, don't ask them to comfort you. Try to be strong to comfort them. And don't feel that there is a right or a wrong way to grieve or to go through an illness.
Mm.
Everyone does it in their own way.
That really goes back to what you said. We can't come in with our own agendas. When God calls us to be with somebody who's in their last days and with their families, we cannot walk in with our own agendas.
Right.
And I think that's a real temptation sometimes.
Mm-hmm. Mm-hmm. Very much.
I think I would also love for maybe those who are participating would like that list of don'ts in writing too.
Okay.
If, you could add that into your email. I think that's, and I think I would add to that one, I understand what you're going through.
Yes. Thank you.
I cringe when I hear that one.
I'm writing it down, but you're right. Thank you. We don't understand.
And
but I think
sometimes we need to realize too, even if we've been through the same thing somebody else is suffering, well, no matter what it is, we don't understand how that person's experiencing it because we're not that person.
Right. Suffering is intensely personal. And that's the one thing that medicine can't understand. But we can try to understand. I think it's really our job to try to understand what this suffering is like for that person. So asking questions and listening deeply can help us to do that. But to say we really do understand, no. I think I've often said, thank you for sharing this. It gives me some insight to what you might be feeling, but I cannot feel what they feel. Yeah.
Or I understand that you're really hurting. I understand that this is terrible. You know,
Yeah.
what you're going through is terrible, you know, that kind of thing. But these blanket statements of understanding. A priest added here, I can't imagine how you feel, the struggle, what you're going through. It sort of opens the door for people to share more about themselves and what they're experiencing.
Right. And a good thing to do would be to reflect on the emotion that you see and let emotion kind of express itself. Emotion's oftentimes a physiologic response, and it takes 20 some seconds to let a cry come through like a storm. And trying to say something during the middle of that storm usually doesn't accomplish anything at all. So if you see emotion that's really powerful, kind of let it roll through like a storm. But then acknowledge it. And usually when you acknowledge an emotion that you see, the conversation goes deeper and more things happen.
Any closing remarks you would like to offer?
Yeah, I didn't get to the vicarious trauma that I promised to get to.
Well, for those who can and want to stay on, why don't you keep going? For those who need to get off, you can watch this once it's been the rest of it once it's archived in the next several days. Is that okay with you, Tom?
Sure, I can.
Okay.
Right. So in general, vicarious trauma is trauma that you witness or loss that you witness by listening to accounts or observing grief or loss or death. So it can cause a reaction in the person who's witnessing it. It could be a negative reaction. The person can become more fearful or cynical, more depressed. They can experience compassion fatigue, where this is just too much, they have to withdraw. Or they can respond neutrally to it. They can find ways to cope and support themselves by certain strategies and becoming resilient and able to manage the trauma that they're seeing and experiencing, but it doesn't change them. That's sort of a neutral response to vicarious trauma. But you can also have people who respond positively to vicarious trauma, in that the things they see and hear are inspiring to them. It changes, transforms them in some way or another by witnessing another person's resilience or strength or the way they cope or the way they're transformed. That's called compassion satisfaction. So I think in my experience, I've experienced all these kind of things. I've had negative experiences of witnessing trauma, neutral experience, and where I kind of, usually that's my usual thing. I probably float along in this neutral zone, coping, finding strategies to cope when I see difficult things in front of me. And occasionally I've experienced compassion, satisfaction, where it's really given me some inspiration. Risk factors for negative experiences of trauma and loss would be social isolation, prior traumatic experiences, a person whose personality tends to avoid feelings or withdraw, or to assign blame to others or something else in stressful situations. Or constant intense exposure to trauma is another risk factor. And finally, a lack of a supportive process for discussing these traumas would be a risk factor.
That's where the wives come in a lot of the times.
Yeah, it's really good to be married to somebody who is experiencing some of the things I am too.
Yes.
And that's really excellent support. When you see negative reactions or symptoms related to that, there's difficulty managing emotions in people who are having negative reactions. The emotions spill out in inappropriate times. They just seem to be right on the surface, and they interfere with normal functioning. There's sleep difficulty. There's sometimes physical issues when negative processing of trauma occurs. There's loss of sense of meaning in life. There's withdrawing, some relationship problems. There's a feeling of being vulnerable so that things that shouldn't hurt way too much. There's destructive coping like drinking, drugs, those kind of things. There's a decrease in enjoyment in activities that should be enjoyable. There's avoiding work and interactions with people at work or parishioners would be the negative things that are experienced.
And those are warning signs that we need help.
Right. Things that might help when trauma occurs, when you're witnessing it, would be to allow the person to talk or to find a way to talk it out yourself. To have a person you know you can go to who will listen. Not a person who will try to fix it, but a person who will listen to you. You don't want somebody who's going to offer only advice. Advice doesn't always do the trick. You want somebody who's going to be slow to do that, who will hear you out and not be judgmental about the things you've experienced. Physical things would be attending to the basics, like making sure you get good sleep habits, and eating and exercising and praying are the physical things you can do for yourself that contribute to a better way of handling trauma when you see it. Repeated trauma especially. A lot of deaths in a parish, for example, or the death or one or two of a young person unexpectedly is particularly troubling and difficult to deal with. There are local bereavement organizations, often in communities. Often it's done by hospice. Our hospice, for example, has a bereavement organization that is open to anybody who's experienced loss. So it's not only closed to people who have gone through hospice services, but is open to a family who's had a loved one killed in an accident, for example, can partake of the bereavement services of our hospice. So hospices often tend to offer that to people. And you might, as a clergy person, locate the bereavement resources in your own community. There'll probably be some. Chaplains at hospitals are another good resource. There are chaplains for emergency services who go through these things all the time. They might be resources too to help clergy deal with loss that's repeated. Spiritual fathers are helpful oftentimes with this too. I think it's important to pay attention to a person's schedule during times of high stress like this too. And I think you need to say no to things that aren't so important. And you know what they are. I don't know what they are in your own particular case, but you know what they might be. And you have to say no to those and delegate those to other people. And you also need to remember that you're not indispensable. That's a hard lesson sometimes for us to learn. in the positions that we hold. But that's really an important lesson, that God can move on and without me and use other people too. So remember that we're not indispensable. Journaling and writing are helpful ways of talking about the trauma that you experience, and getting that out, especially if there's no person around you that can listen deeply in the way that you need, or if you're a person who finds it difficult to talk to another person in that way. Journaling can be very helpful. For the spouse of a clergy, I would say, or anybody who actually is witnessing trauma and needing to talk, I would say, don't take their reactions personally. I mean, you can come out of a situation that's very difficult, a loss that moved you or made you angry about how things took place, or maybe even in your own role, that you wish you would have played your own role differently. And your emotions might be really high, and you might want to throw things or something like that. The spouse or the loved one that's close to this person who witnessed trauma must not take their reactions personally. It's not about them. Let them vent. Let them say these things, and don't be judgmental. And maintain your daily routines, and that predictability can help. It can help lend some structure to life. And make sure that you have a non-judgmental space available for people to vent. One other thing is, I would say, learn how to develop some boundaries. Our hospice talks about that for its staff. It's easy to get connected and pulled into very compelling stories and events in people's lives. But it's not your story. It's not your life. You have to separate yourself from that in order to be helpful, and find ways to set your own boundaries.
There's an outstanding book, and I'll put this in the email too. It's more general, but it does pertain to what you're talking about, and it's specifically for clergy, and it's called Saying No to Say Yes. I can't remember the author, but it really talks about appropriate boundaries, life-giving yeses, and versus yeses that are just for the sake of people pleasing, those sorts of things. So I'll make sure that I put that information also in the email.
I'll look forward to seeing that. So,
I think we probably should bring this to a close. Is that okay?
Yes.
Because we're getting to 4:15 and we've gone over. This has been wonderful. Thank you. You've scratched the surface on a lot of different issues, and my hope is that maybe we can have you come again to dig even more deeply into some of these issues. But I think you've given us a wealth of knowledge and wisdom coming from a place of a lot of experience and a real love for Christ and his church. And that's what we all need to support one another as we all do ministry. So thank you. Thank you very much, Tom.
Thanks. I've appreciated the opportunity, and I'd be happy to be back again.
And I'm getting some thank yous here in the question box. So what you have offered is very appreciated. Thank you.
Thank God.
All right, everybody, until the next one. We'll see you in hopefully 2 months for our next webinar. No title, no speaker yet, but it will be forthcoming. Thanks.
Thank you.